So good morning. My name is Apurva Shah from the Children's Hospital of Philadelphia. I'm going to be speaking to you about pediatric distal radius and ulna fractures, and I want to focus on some of the new research that we've been doing at CHOP, since I know this is a topic that's well known to you all. We're going to share with you data on coronal plane remodeling, and then specifically the incidence and risk factors for growth arrest following physeal fractures of the distal radius and ulna. We know that distal radius fractures and distal ulnar fractures represent 25% of all fractures in children. And of course, the majority of these fractures are innocuous varieties like torus fractures or green stick fractures. But the physeal fractures and the bicortical metaphyseal fractures can cause trouble both with respect to growth arrest and potentially in some cases needing surgery. Of course, given the proximity to the distal radial physis, there is great potential for remodeling, and this minimizes the surgical rate in children. Now, the distal ulna fracture is often an associated fracture that occurs with the distal radius fracture and generally plays no role during the initial treatment, but we do want to focus today on the physeal fractures of the distal ulna and share with you some new information. Now, as I noted, the remodeling potential of the distal radius provides substantial potential for non-operative management. You can see in this case of a Salter-Harris 2 fracture, the excellent remodeling that occurs after a significant dorsal angulated translated malunion within 6 months. The potential for remodeling was well highlighted by the research group in Hawaii that studied 51 consecutive children with overriding distal radius fractures, like you can see in the bottom left. In this group of children who were treated without reduction and without surgery, the final sagittal angulation was 2 degrees and the final coronal angulation was less than 1 degree. And you can see the remodeling in their case series as an example. Though there's some shortening of the radius, the overall outcome is good without reduction and surgery. Now, the potential for remodeling in the sagittal plane, which is in the plane of motion, has been well studied by a number of investigators, but there's been very little research on remodeling in the coronal plane. And that's what our group thought to do, which was to look at the potential for coronal remodeling, with the hypothesis that this would occur at a rate of greater than 2 degrees per month. We looked at patients who had at least 4 months of radiographic follow-up and at least 10 degrees of coronal angulation following reduction. For each of these patients, we calculated a coronal remodeling rate based on the angulation at the time of injury, the angulation at final follow-up, and the duration of time in between these two events. On average, in our cohort, the typical patient experienced remodeling at 2.5 degrees per month in the coronal plane, and none of our patients had residual translation in the coronal plane that exceeded 10% at final follow-up, suggesting the excellent remodeling that occurs in this plane. Here's a case example from our series, 34 degrees of angulation, while in a cast, approximately 6 weeks after injury, this is already reduced to 14 degrees, and then 8 months after injury, it's down to 10 degrees, highlighting the very significant remodeling that occurs within 1 year of injury. We concluded that the average coronal remodeling rate is approximately 2.5 degrees per month, and at least 20 degrees of coronal angulation is acceptable in a child with at least 2 years of remaining growth. For all of these reasons, we have relatively strict operative indications. We are trying to push non-operative management as far forward as possible. And I've listed for you here criteria of what we would consider to be minimal angulation and translation before considering surgery. Of course, we have to pay particular attention to children with physeal fractures, as late reduction or repetitive reduction attempts in these kids can affect or increase the potential for physeal arrest, and special care must be given. We know that physeal fractures of the distal radius are common and represent nearly 20% of all physeal injuries. Our research at CHOP and our collaborators in a prospective US registry suggests that Salter-Harris 2 fractures are the most common, with an 85% rate, followed by Salter-Harris 1 fractures at a rate of 12%. The intra-articular type 3 and type 4 fracture patterns are relatively rare and affect approximately 4% of patients. We recognize that poor management of the physis during injury can lead to trouble, with the distal radius providing 70% of longitudinal growth, or approximately 5 millimeters per year. Now, the incidence of physeal arrest has been well studied by a number of our peer investigators over time. In this important study from Rome in 2003, Kanata et al. Looked at 157 fractures with a mean follow-up of 25 years. In their cohort, 4.4% of children developed a growth arrest, but they were only Salter-Harris 1 and 2 fractures. Notably, they reported on 6 children with a distal ulna physeal fracture and suggested that 50% of these patients developed a physeal arrest, which is a number that stood out to me in my training. Of course, it was based on very few patients. The group at the Children's Hospital of Philadelphia, now nearly 40 years ago, looked at 100 physeal fractures of the distal radius. In this cohort from CHOP, again, several decades ago, 7% of the children developed a growth arrest, but notably there were some type 3, type 4 fractures in this cohort. When I was a fellow at the Boston Children's Hospital working with Don Bay, we looked at specifically the type 3 and type 4 fractures. We had 28 patients with type 3 or 4 injuries, and notably the growth arrest rate in this specific cohort was 43%, suggesting that there's a really big difference between the type 1 and type 2 fractures versus the type 3 and type 4 fractures. It's really an apples to orange comparison. And these patients need to be followed very carefully, or maybe considered for a primary epiphysiodesis of the distal radius. Now, I wanted to bring to you new data from the Children's Hospital of Philadelphia. We recently looked at 536 physeal fractures with a median age of 9.5 years. And in our large cohort, we found an overall incidence of physeal arrest of 6.9%. We wanted to look carefully at what the risk factors were for a growth arrest. And specifically, when we looked at age, children with greater than 10 years of age were 6 times as likely to experience a growth arrest. The Salter-Harris pattern did play a role. We did not have enough 3 and 4 fractures to comment on that specifically, but the type 2 fractures were 3 times as likely to experience growth arrest as the type 1 fractures. As you would expect, initial traumatic severity, in this case, coronal angulation and translation, also affected the rate of growth arrest. And even more impressively, the initial sagittal angulation and translation affected the growth arrest, such that more than 5% of sagittal translation resulted in an increased risk of growth arrest by 7.2 times. Of course, the children who required a closed reduction were more likely to go on to growth arrest, and importantly, the children who had multiple attempts at closed reduction were far more likely to experience a growth arrest than the children who had a single reduction attempt, with an odds ratio of 7 times, suggesting the importance of minimizing iatrogenic trauma. In multivariate analysis, we only found 2 variables to predict the risk of growth arrest, which were age greater than 10 years and initial sagittal translation of more than 5%, which in multivariate analysis increased the risk of a growth arrest by 4.5 times. So from our recent data, we can suggest that the physeal arrest rate may be higher than previously reported at 6.9%, and that specifically older children and those with sagittal translation have an increased risk of physeal arrest. Now, we all recognize distal radial growth arrest to be an important issue because positive ulnar variants can lead to impaction and pain in children. I think it's important that this be detected early on screening radiographs when the patient is asymptomatic. Of course, if it's detected late and there's already length discrepancy between the radius and the ulna, then that child will be symptomatic. For these reasons, we radiographic screening in children 6 to 9 months after injury so that you could consider an earlier epiphysiodesis. And just finally, I wanted to focus on recent data on distal ulnar physeal fractures. I want to thank my colleague, Dr. Vark, who's on today's call, who collaborated with me on this research. We specifically looked at 56 patients with distal ulnar physeal fractures to assess the risk of physeal arrest. In these patients, 41% had displaced fractures and 70% had concomitant distal radius fractures. The physeal patterns were different than the distal radius, with a larger number of patients with type 3 and type 4 Salter-Harris patterns. 23 of the 56 patients required intervention, including 18 who had a closed reduction and 7 who underwent ORIF. We followed these children longitudinally, of course, looking specifically at changes in ulnar variants. In our cohort, 19.6% of patients, or 11 of the 56, demonstrated signs of either growth disturbance or growth arrest. we specifically found that children with displaced fractures and type 3 and 4 injury patterns were more likely to develop a growth disturbance. Less children specifically with less than 2 years of skeletal growth had the highest risk of growth disturbance with 46% versus 9%. And you can see that 8 of our patients developed a complete growth arrest, though the majority of these patients did not require surgery in the form of ulnar lengthening. So in conclusion from this cohort, we found that the distal ulna physeal fractures have a lower rate of physeal arrest than previously reported, and that specifically the type 3 and type 4 fracture patterns had a much higher risk of growth arrest at approximately 50% versus an 11% risk in the type 1 and type 2 patterns. Notably, displacement and requirement of reduction, or whether it is closed or open, significantly increase the risk of growth disturbance. So in summary today, I would like to say that in our data at CHOP, approximately 7% of children with distal radial physeal fractures experience growth arrest, 20% when having a distal ulna physeal fracture. There are high-risk patterns that I believe require careful monitoring, either type 3 or type 4 fractures in either bone, or children with greater than 10 years of age in the radius, or more than 5% of sagittal translation of the radius, and with the ulna, the kids who have displaced fractures requiring reduction. Of course, our management of children should be influenced by the remodeling potential. Very few children need surgery. At CHOP, that number is less than 2%. And I would specifically urge you not to worry about coronal plane deformity, given the significant remodeling potential. Thank you.
Okay, thank you very much. Thank you for your nice talk. Wonderful cases of remodeling and wonderful data of CHOP. Do you have any questions or comments from the audience? Questions? Okay, from Dr. Wang. Distal ulnar physeal arrest analysis. Do these include ulnar fractures? These would be fairly benign for risk of physeal arrest and may impact your low numbers of arrest.
Yeah, so if there was a ulnar styloid fracture that was specifically a Salter-Harris 3 or 4 fracture pattern, then it was included in this study. But if it was a styloid fracture that did not involve the physis, then it was excluded from the study. So the 56 patients were strictly patients who had a physeal injury to the distal ulna, not an extra physeal fracture.
Mm-hmm. And from Andres, you mentioned the Crawford paper of Hawaii. Do you actually use that kind of conservative treatment?
Yeah, it's a timely question. We're involved in a prospective multi-center trial now with the Lurie Children's Hospital in Chicago, where patients with that fracture pattern are being randomized to non-intervention treatment, so simply casting alone versus a closed reduction in cast to look at the long-term outcomes. I think it's important to look at this in a randomized way, which we're starting to participate in. In fact, we enrolled our first patient into this trial on Friday.
Okay, any other questions? And I have one simple question. The most case is type 2, sort of highest type 2, but lower rate of the physeal arrest for type 2. But can you predict the physeal arrest for the sort of highest type 2 at injury?
Yeah, so that's the most common pattern. And I would say that the way I was taught by Peter Waters and Donald Bay was to screen all of those children 6 to 9 months after injury for physeal arrest. Mm-hmm. But I think with our new data, you can restrict your screening to a smaller group of children. Like I mentioned, particularly those who are more than 10 years of age and those who have sagittal translation at the time of injury that exceeds 5%, which of course is a very small number. But those two pieces of information, the age and more importantly, the sagittal translation, increase the risk of physeal arrest. So you can see in that multivariate analysis that the kids with more than 5% sagittal translation had a 4 times higher risk of growth arrest. So I think if you do the relatively basic math, that puts that specific cohort at approximately a 25% risk of having a physeal arrest, which I think is a pretty high number. And as noted, I think it's important to detect those early, particularly in the children who have maybe 2 or 3 years of growth remaining or less, because in those children, I think all of us would consider a distal ulnar epiphysiodesis prior to becoming symptomatic. Of course, early detection in the very young child, if you're 8 or 9 or 10, probably doesn't matter, because in those kids, we're going to think about a radial lengthening or an ulnar shortening or both, and early detection may not make a difference. But I think screening the children with residual sagittal translation for physeal arrest, particularly those within 3 years of growth completion, is very important to recommend early epiphysiodesis if they do experience that growth arrest.
Okay, thanks. Another question. You have shown nicely that repeated manipulation results in higher rates of physeal arrest for the radius. Is there any correlation between timing of manipulation and growth arrest?
Yeah, I'm embarrassed I don't have that data for you today. I was hoping to have that analyzed before this morning's session, but we're just not quite there. We have over 500 children in the series. We're hoping to double that number with our collaborators from Boston. Then I think we can get you better data on the timing of reduction. But I would say that since Dr. Lee's paper was published in the US in 1984, very few American surgeons are inclined to reduce the radius within or outside of 7 days from the injury because of that early data that suggested an increased risk of growth arrest. And I think it is likely that the children for whom we are considering late reduction are by and large older children who are closer to skeletal maturity, because in those kids, the alignment may matter more than the potential for growth arrest. So it may be a somewhat difficult analysis to come through, but I hope to share that data with you, and please look for our paper sometime in 2025.
Okay, thank you. And any other questions? When do you recommend the bone lengthening for the physeal arrest cases, early arrest cases? Although I think it depends on the cases. When do you recommend bone lengthening?
Yeah, it's a very good question. I think for the ulna, you saw that very few children ended up with surgery. And I think in general, the children with ulnar growth arrest can be treated non-operatively. Of course, the youngest children, if there's substantial growth discrepancy with the radius and the ulna, like we see with multiple hereditary exostosis or other conditions, this can lead to severe radial bowing and even dislocation of the radial head at the radiocapitellar joint. So those children, I think, need to be treated with lengthening, either acute or distraction lengthening, to avoid pathology of the radiocapitellar joint. The distal radius is a little bit trickier, but I would say in general, the kids who have, let's say, more than 4 years of growth remaining, we may consider a lengthening procedure of the radius, either a distraction lengthening or an acute lengthening with iliac crest bone graft. I think if a child has less than 3 to 4 years of growth remaining, and I'm anticipating the final discrepancy to be less than 2.5 centimeters, then I personally would favor an ulnar epiphysiodesis and an ulnar shortening just for surgical simplicity. But there's probably some, disagreement in the room on this issue because, I think both options are reasonable in that transitional age child.
Okay. Okay, thank you. Thank you very much, Dr. Shah, and I appreciate it.